Assalamu alaikum. I hope you all are good and preparing well for the exam. Who is doing the recalls with every unit and the expert quiz file that is present in the notes. Okay, if you want to present there, you must do daily 2 quizzes, 2 or 3 quizzes. Okay, on daily basis, not only the MCQ, the topics. Also, when you, as like I am teaching general level, you must go through the 1 LF file I have provided, MCQ file. There are 1000 points. You must go through that file. Okay. So yeah, listen my lecture. If you have American on doing that, okay, system wise, and also do the recall file. I have provided them I file with the 1000 points. So you will get the idea which points are important. That should be on your fingertips. And the expert recall file that should be on. Okay, today our topic, our discussion is cranial neuroanatomy. After this session, maybe I will be busy. Either I will conduct one session on Tuesday. Before that, Dr. Bang will teach. The next plan I will tell you. So first MCQs, just read it and then answer them. So you all know that's very easy. Auto by accident, alert, examination, vehicle and nasal discharge, bruising around the eyes. So patient has the of anosmia, mean loss of smell, sensation. So that is fracture of cribriform head. Cause nerve fibers from the nasal epithelium that enters the cranial cavity via the cribriform ethmoid bone. That you must remember. The most common nerve that affected that is in trauma, that is the olfactory nerve that you must remember. So the function is sense of smell and to do the assessment of smell to assess this nerve. Causes of injury that can be local nasal disease, tumor of frontal lobe, meningitis, trauma, fracture of ethmoid board, hand disease. So that these things you must remember. Next. Yeah, that is BC. So first question is with a sudden painless loss of vision, monocular vision loss that we discussed in the previous session in CNSA, that is optic nerve, that you must remember. Okay, fundoscopic release swollen optic disc. Okay. And third, presented emergency problem with persistent headache, vomiting, colored vision. That means the intercranial pressure is increasing, bilateral papilledema. So optic swelling increase intercranial pressure because what that happened because optic nerve sheath that is related with the subarachnoid space. So increase the indical ratio, that will also compress the optic nerve sheet. So that's why it happens. So optic nerve that you must remember, surrounded by the cranial meninges, enter the scan canal via optic canal of the sphenoid bone. That very important to remember, their entry route, exit route. So if there is any injury, any fracture here, so that can cause the damage to that nerve. Okay, so optic canal of sphenoid bone that enter the skull via this. So that you must remember. To see blood supply from the anterior cerebral ophthalmic central retinal. If there is any problem with the central retinal or the ophthalmic, that can also lead to the uh, dysfunctioning of the optic nerve. Function vision afferent pathway of pupillary. So that's you must remember of pupillary right reflex afferent A for before 2, 3. So pupillary right reflex 2, 3. So second nerve will be afferent and third nerve will be efferent as E comes after the A. So that's how you can remember. So how will we assess this? We assess with the Snell chart to assess the visual acuity, color vision, Schara plates and pupillary light response, optic disc, fundoscopy, visual field test, visual pathway. And then the ipsilateral monocular visual loss of color vision. That's the if there is an injury that will lead to the monocular visual loss of color vision, abnormal pupillary light reflex. So the causes of injury that can be, it can happen in the optic neuritis. That's very important. We discuss in the CNS too. Multiple sclerosis that can lead to the optic neuritis, and optic neuritis that can be the injury to optic nerve compression and orbital cellulitis. That's very important. And glaucoma, optic nerve toxicity, trauma, orbital fracture, penetrating into the ischemic candy. So these causes are very important. So lesion that will lead to the ipsilateral or monocular visual loss. Okay, on which side the optic nerve damage, that there will be visual loss on that side. Okay, loss of color vision in the ipsilateral eye, abnormal light reflex. These are the common. So other thing that's important is loss of pupillary light reflex seen in complete transaction of the optic nerve. That's very important question, has been asked many times in exam. So there is a relative afferent pupillary light reflex seen in the optic nerve. So how will you remember this? As you can see that it causes ipsilateral direct reflex loss. Okay, if there is right eye nerve effect with effective. So if you will put the light in the right eye, there will be no direct effect. Okay, and there will be contralateral consensual reflex lot because it's afferent that takes the message to the brain. Okay, so what will happen? So if there is a contralateral consensual reflex loss and contralateral direct reflex, that will be intact. So that question is a common. You can see that when you will put the light here, okay, when you that is a direct reflex. Okay, consensual reflex, that mean that in other eye there will be also a small effect of the pupillary light reflex. So when you will put the light here, so what is the consensual, that you will follow the light here. Okay, so when you will put the light here, then here, so there will be effect here. So that's it's called the consensual light reflex. So how paradoxical relative appearance without how will you assess this? How will you the MCQ? If there is a affected eye, okay, this right one is affected eye. Okay, so you put the light here. So what will happen? As there is this is affected eye, there will be no direct reflex. Okay. So when you will put the light in the affected eye, after being shown in the unaffected, first you will put here, then you will put in the affected eye. So what will happen? Affected eye will still sense the light and constricts. So because this eye is normal, so its efferent and afferent are normal. So efferent will go there, okay, and it will give a small signal. So there will be a small extent of uh, reflex here. So that's affected eye still senses the light and constrict, but to a lesser extent than when the light is shown in the unaffected eye. Therefore, pupils appears to be dilate. So there will be a small extent of effect, but pupils that will seem dilated. So that's the question will be asked about this. This is a very common question in the exam. Next question. Okay, so that's very easy. So first is the bitemporal, that is the optic yaw. We have discussed sudden loss of vision in the right visual field of both eyes and left occipital, which are the following. Left occipital lobe, because it has a dual blood supply that we have already discussed in the CNS. So it has a dual blood supply from the middle and posterior cerebral artery. That's why it will be a macular sparing. Visual pathway, so that's we have discussed rods and cones, that's the first order receptor, bipolar neuron, that's the second order neuron, and optic nerve that is formed by the convergence of the axon from the retinal ganglion cells. Leave there, we discuss about the optic canal, optic yaws, optic nerve from each edge united to form the optic yaws that you can see in the image. Optic tract, so fibers from the medial half of the each retina crossover. So that you must remember nasal fibers that are crossing over, but not the temporal. Temporal will go on the same side. Left optic tract contains the fibers from the left lateral, left temporal retina and right medial and nasal retina. Okay. The right optic tract that will be same the temporal, right temporal or right lateral and left nasal retina. Each have traveled to the corresponding cerebellum to reach its lateral geniculate party. That's you must remember about the in the thalamus lateral geniculate party. From the light, you must remember the lateral geniculate party related to eye. Next question. Sorry, there was internet problem. Okay, so what were you answering for the question number 3? Four. Okay, so the female present with the severe postictal visual disturbance, she report loss of the optic right quadrant of vision in both eyes. Okay, lesion is suspected in the temporal lobe. So, which part of visual pathway is most likely involved? So, if it is in the right quadrant, so where will be the issue? Yeah, left side. So most of the people were choosing left upper optic parietal. That's the temporal. It's written a temporal. So that the Mayer's loop is also called the temporal. Okay, so that was Mayer's new thing. But you must remember that it is for used for temporal. That was left Mayer's loop. The answer. Okay, I think you got confused with the Mayer's word. A man with uncontrolled diabetes presented with a sudden onset right humnominous semnopia. That's very easy. So that is left optic tract. Okay. Visual pathways we have discussed. Optic radiation carries fibers from the superior retinal quadrants corresponding to the superior visual field quadrants that travel through the parietal lobe, and lower optic radiation carries fibers from the inferior retinal quadrants corresponding to the superior field quadrant. Radiation pits, we discussed about it. Pits, parietal, upper optic radiation, pits mean inferior contralateral humnominous, inferior chordotropia. Temporal, lower optic radiation, TS temporal, superior chordotropia. And occipital, that's contralateral humnominous, humnopia with macular sparing because of dual blood supply. This is the diagram you must know that we have discussed PNS. Okay, so you can see monocular visual loss, lesion aroptica on the bitemporal, humnominous synopia lesion optic tract, contralateral, humnominous synopia lesion parietal upper optic radiation. So you can see the inferior, that temporal superior, that you can see the macular sparing area. Next question. Then to the infant with sudden onset of ptosis, diplopia. On examination, his right eye is deviated down and out. The pupil is spared. Any headache or trauma? What is the most likely underlying cause of his presentation? Very easy question. Why everyone is answering A, B, A, B? So it's diabetes. Okay, what happened with the diabetes patients? Underlying cause. You have to tell the underlying cause. Diabetes lead to neuropathy. Okay, microvascular ischemic neuropathy. So that was the question of diabetes that have led to the micro ischemic neuropathy. So that's why cranial nerve 3 that does it from the midbrain and exits skull through the superior orbital. So you must remember about the superior orbital fissure, which nerves are exiting from here. Function: innervates for extraocular muscle, inferior oblique, superior, inferior, medial, right, erector, levator, superior muscle. Sphincter in the pupillary constriction, ciliary muscle accommodation. That's very important function. You must remember. Efferent pathway plus pupil right flex. Eye movements accommodation that will be assessed with clinical effects down and out. Eye. Diplopia, ptosis, fixed and dilated pupil with loss of accommodation, abnormal pupil light reflex. Tumors, aneurysm, posterior communicating, so subdural, epidural hematoma, diabetes that can be the cause of. Next. Why are you taking so lot of time? So road traffic GCS is low, left pupil and CT position show right sided temporal lobe continuum in midline. There's a midline shift, so that's what happened. So left eye is non-reactive, okay. Right eye is non-reactive, left eye is reactive. So that means right eye is deviated. So it's causing the compression of the oculomotor nerve due to uncal herniation, okay. So that's a very common question that you must. That's the oculomotor nerve tract. Next. Okay, hurry up. You're taking a lot of time. So first question is minor road traffic accident when the vertical diplopia. So that's very easy, vertical diplopia. Most of the time they will not mention in the question about the vertical diplopia. Okay, so when he walks downstairs, reads the book. So that's yeah, that they will tell the patient will feel difficulty in peeing when he walks downstairs. That's how the question can be asked, and head tilt to the right. So that is on, there is an issue with the left trochlear nerve. So vertical diplopia, left trochlear nerve. It supplies which muscle? It supplies which muscle? SO4, clear oblique. Okay. So that you must remember. Next question. Fall from stair with the mild head injury, complaint of double vision. Down gaze, CT head is the further assessment. Null deficit, you suspect isolated trochlear nerve injury. Which of the following best explain the vulnerability of the trochlear nerve in closed head trauma? What about the 7? Question number 7. The answer is B because it has the longest intercranial course and decussate in the midbrain before exiting dorsally. So that where there is great chances of trochlear nerve injury in the head trauma. Pressure from the midbrain travels the latest effect of the cavernous exit skull through the superior orbital fascia. Motor splice, superior oblique muscle, it causes endoreal depression. Assessment, eye movement, weakness of the downward gaze, difficulty reading, walking, vertical diplopia, eye is extorted, may be elevated. Causes of idiopathic trauma, macrovasculopathy, cavernous sinus, disease, dazed intercurrent pressure. Okay. Next. Okay, first is the facial trauma following a road traffic accident examination. There is a loss of corneal reflex and hyposthesia over the forehead. Okay, so which nerve is affected? You most of the time, why you are answering? D. So one. Okay, A, D, A. Yeah, the answer is A, ophthalmic. Okay. Over the forehead, which we are trying, that's from the loss of corneal reflex, and forehead, that is the branches of ophthalmic that fly the forehead. And then female with severe facial pain along her upper lip and cheek is diagnosed with trigeminal neuralgia. So, which division is most likely involved in trigeminal? That is maxillary division. Okay, maxillary division. First is ophthalmic for question number 8. Okay, and then second is the maxillary division. So, it arises from the brainstem, exit from the pons, lies the muscle of mastication, tensive and intensive reliability. We discuss the jaw jerk, sensation of pace, cornea blink reflex, power. So you must remember the cornea reflex, 5 and 7, afferent from the 5 and 7 efferent from the 7. Clinical effects, pressure tells the muscle of mastication, jaw deviation toward the affected side. That's very important. But jaw will be toward the affected side. Loss of sensation to the face, loss of sensation of afferent corneal reflex, loss of jaw reflex, causes of injury that can be trauma, unaccessible tumors, corneas, cavernous sinus. We discussed the branches and everything further, okay? After this. Okay, so answer for the 10 is C because there is a jaw deviation in the left on opening after mandibular trauma. So which branch is that? And next is the anterior two-third. That's very important. Have been both. These are important questions. Tongue that have been asked many times. That is the lingual nerve. Okay. Anterior two-third. That is by the lingual nerve. Anterior two-third of the tongue. That sensation is by which nerve? Taste. Sorry, taste is by which nerve? Seventh nerve. Branch name? Chorda tympani. So the trigeminal nerve have three branches: ophthalmic, maxillary, and mandibular. So you must remember that it exits the superior orbital fissure, give the three main branches. Ophthalmic nerve, when it exits through the sphere, it gives three main branches here. Frontal nerve, okay, and next lacrimal nerve and nasociliary nerve, okay. So that's frontal nerve. There is supraorbital branch and supratrochlear branch. You must remember this image. Supraorbital is innervated skin of the upper eyelid, conjunctiva, skin of the upper forehead, extended to the middle of the supratrochlear, innervated in the skin of the lower central part of the forehead, skin of the upper eyelid. So you can see the distribution of these nerves. Next, Okay, maxillary, that should be from mid-face trauma, little nose. Upper lip maxillary teeth, which form that's the maxillary nerve. So foramina rotundum and ED patient with a basic skull fracture present with absent jaw reflex. Which structure is likely? Absent jaw reflex. Which nerve? Mandibular nerve. B3. Okay, so that's must remember. Cranial ophthalmic nerve, lacrimal nerve in the skin of the lateral half of the upper eyelid. Injectiva skin in the area of lateral angle. Nasal ciliary and nasal ciliary, you must remember these green words. These are very important. External nasal and infratrochlear. Others are interior ethmoid, posterior ethmoid, long ciliary, but these two are very important. External nasal, innervating on the interior part of the nose. Infratrochlear with the medial half, upper eyelid, conjunctiva, bridge of the nose. Okay, so they will give a bridge of the nose. And long ciliary sensation over to the eye, cornea, ciliary bodies, anterior ethmoid and posterior ethmoid. Then is the maxillary nerve. Maxillary nerve enter the pterygopalatine fossa through the foramen rotundum. That you must remember, foramen rotundum or from or rotundum. So that's how you must remember. In the cranium, in the middle meningeal nerve, in the pterygopalatine fossa, temporal nerve, zygomatic-facial. These are very important. Temple above the zygomatic arch, area of the interior temple, area of the skin of the zygomatic bone, infraorbital, middle sphere, alveolar nerve, sphere, infraorbital nerve. That's very important. They are within the lower eyelid and upper lip. That's you must remember. On the face, inferior palpebral nerve, sphere, labial nerve, lateral nasal nerve. Then is the mandibular nerve, key anatomy, arises in the middle cranial fossa, exits skull to the foramen ovale. Okay, ovale. That's you must remember. That can be asked. Sensory lower lip and chin. Lower teeth, gingiva, floor, oral cavity, interior two-thirds of tongue, temple, temporomandibular, motor function, muscle of mastication, tensor tympani, tensor villi palatini. Facial function, post-ganglion fiber to parotid gland. Branches, buccal nerve, innervating the skin and mucosa over the cheek. Steady innervating masseter muscle, deep temporal nerves, nerve to the lateral pterygoid muscle, posterior deviation gives rise to the auriculotemporal, very important, lingual, irrelevant. These three are very important. Auriculotemporal, skin over the temple, external layer, external auditory meatus, inferior alveolar nerve, lower teeth, skin of the lower lip. Very important nerve. Okay, that's have been asked. Auriculotemporal, inferior, and these three are very important. Have been asked many times. Interior two-thirds of the tongue. That is sensory lingual nerve, which is the branch of mandibular nerve. So the question can be asked anyway. They can ask loss of sensation of the tongue. So they can ask about the trigeminal nerve, its branch mandibular nerve, then its sub-branch lingual nerve. So anyhow, they can ask anyway. Okay, 14, the answer is 6 now. That's very easy. And you will abduct the right eye. That's the later area, LR6, that you must remember. So, unable to abduct the right eye. Susceptible to abducted nerve to injury and increase integral pressure. What explains more? Has the longest subarachnoid cord. So that's if there's anything that subarachnoid is an increase in integral pressure, so that will affect those nerves. Abducted nerve exits scale through the superior orbital fissure. Function later rectus muscle of eye, abducts the eye, assessment, eye movements. So there will be horizontal diplopia, convergent squint, that you must remember, causes of injury, Wernicke's Cox syndrome, diabetes, extrahematoma, cavernous sinus disease. That's very important. Wernicke's Korsakoff syndrome. That's in that sixth nerve can be affected, and also in the cavernous sinus system. Third nerve. Next, I mentioned in my session. So why are you answering for 16A? Okay. It's a distracting. Chordate tympani, yeah, it's the chordate tympani. But you must see where the injury is. Okay. Injury is at the level of parotid. So that two-thirds after parotid surgery. And patient Bell's palsy can't wrinkle his forehead. That is lower motor neuron, upper motor neuron. That is lower motor neuron. Okay. So we will discuss it. E naught means cerebellopontine angle, exit brainstem, and internal auditory matters that you must remember, and via skull through the mastoid foramen. Motor function, there these are muscles, here, digastric, xyloid, stapedius, that's very important. Lacrimal, salivary gland, pharyngeal, corneal brain reflex. Taste to anterior two-thirds of the tongue. Okay, assessment, facial movement, corneal brain reflex. Due to injury to stapedius, that will be hyperacusis, impaired sensation. That's these are very common. Bell's palsy, Ramsay-Hunt syndrome, that you must remember. GB syndrome, that will lead to the facial nerve injury. Okay, so you can see within the temporal where it rise to three main branches. Down to the stapedius, greater petrosus, cauda tympani. So the sternum between the styloid and mastoid process of temporal bone. What was the question? In the parotid gland, facial nerve divides into five terminal branches. So it was the main trunk because it was having inability to close the eye, loss of taste, facial droop. Okay, so there was a lot of problem with it. So that's why it was main trunk. If it was only the loss of taste and tear through that, then it was caudal tympani. If it was only facial droop, then this was different. And if the inability to close the eye, then okay. So that was the okay. Develop hyperacusis, taste disturbance after a viral illness. Lesion involved in which part of the facial nerve? Okay, so the answer for both is C. We discussed the lesion involved which part of the facial nerve that is in the facial canal before branching. Facial nerve gives out nerve to radius within the facial canal. That's you can see. Brainstem when the temporal bone where it gives rise to three main branches within the temporal bone. Now to stapedius, greater petrosal nerve, cauda tympani. Okay. Facial nerve exits the facial canal through the stellomastoid foramen between the stelloid and mastoid process of the temporal bone. Facial nerve responsible for lowering the corner of the mouth and is often damaged in submandibular surgery. Facial weakness that spares the foot is usually due to lesion in nine. So that the first responsible for lowering the corner of the mouth, that is submandibular injury, that is marginal mandibular. Okay, it's also motor movement for the lower lip and chin, and it also runs close to the submandibular gland. So it is that it is vulnerable to injury when you are doing the submandibular surgery. Facial weakness, that's where the forehead is usually due to lesion and okay, upper motor. That's you can see once in the parotid gland. So it in parotid gland, give the facial nerve divides into 5 terminal branches. Temporal branch, a muscle of the temple, forehead, supraorbital. Zygomatic branch, innervating the muscle in the infraorbital area. Vocal branch, innervating muscle in upper lip and corner of the mouth. And marginal mandibular, innervating the lower lip and chin. Cervical, that innervating that is muscle, that you must remember. So you can see sensory supply of the upper lip, that is different. Sensory supply of the lower lip, that is different. This is the motor supply. Always they will give this and you will confuse it with the sensory supply. Okay, they can ask about the sensory supply. They can also look that they are asking about the motor. There is a motor dysfunction and there is the sensory dysfunction of the upper lip or lower lip. Sudden onset vertigo, hearing loss, tinnitus. So these are all features leading to Meniere's disease. Okay, and that is affecting the cranial nerve 8. So that is the cranial nerve 8 problem. So due to Meniere's disease. Comprise the vestibular, cochlear component bones emerges from the brainstem, cerebellopontine angle. So that's very important to remember. Enter the internal acoustic meatus of temporal bone. So these you must remember. Hearing and balance, Weber and Renan test, sensory neural hearing loss, tinnitus, vertigo, loss of equilibrium, infection, basical fracture, drugs, cerebellopontine angle, tumor. So Weber test and Renan test. Okay, Weber test when you will uh, place the fork in the midline, so it will be heard centrally. Okay, if it is lateralized to affected ear, that is conductive hearing loss. Lateralized unaffected, that is unilateral hearing loss. So that how you can remember that it will lose its senses. Okay, so what will happen? Sound lateral is to unaffected ear, and conductive hair, that lateral is to affected ear. Renan test, air conduction is more than bone conduction. So in the conductive hearing loss, that will be opposite. Bone conduction will become more than air conduction in the affected ear. In the sensory hearing loss, that will be normal in the affected ear. Air conduction more than bone conduction. So you will assess or diagnose the sensory with the Weber test. Loss of gag reflex on the right side after tonsillectomy. Just damage to which nerve? Which nerve creates sensory input from the carotid body and sinus? Both the answer for both is B. Tonsillectomy is the damage to which nerve. 9. Carotid body, that is also 9. So originate from the medulla exit to the jugular filament. So any injury to the jugular filament that can lead to the injury to the cranial nerve. 9. Posterior 1/3 of the tongue, tonsil, oropharynx, soft palate, middle ear, that is sense infection, motor function, sternopharyngeus muscle, that's skeletal swallowing, plasmic fiber to the parotid gland, gag reflex, that's very important to remember, swallowing, clinical effects of injury, loss of gag reflex, dysphagia, loss of carotid sinus, loss of taste from the. So the posterior 1/3, that is sensation and taste that is applied by the cranial nerve 9, that you must remember. Cause of injury, occipital condyle fracture, lateral medullary syndrome. So develops hoarseness after neck injury, laryngeal disease, vocal cord palate, that is applied by the recurrent nerve. Okay. And which nerve is responsible for plasmic innervation to the most of the thoracoabdominal viscera? Plasmic innervation to visceras are mostly by vagus nerve, nerve 10, that you must remember. Vagus nerve is the medulla, exit is the jugular foramen, larynx, laryngopharynx, external calcium dura mater, that you must remember. Muscle of the soft palate, except tensor palate. So muscle of the pharynx, except sternopharyngeus, muscle of larynx, platoglossal muscle of tongue, visual afferent fiber to the viscera of neck. So an efferent pathway for the gag reflex. So afferent from the ninth nerve, efferent from the 10th nerve. Uvula deviation, that you must remember, it will be same side or opposite side, uvula deviation. Opposite side. Okay, so that's very important to remember. In the exam, they will give left uvula, so answer will be right vagus nerve. Gag reflex swelling, dysarthria, dysphonia, dysphagia, stridor, loss of gag reflex, trauma, neck injury, aneurysm, jugular phenomena syndrome. Next. So it's very easy. That is a accessory nerve, cranial 11. So originate from the cervical segment C1, C5, enter cranial cavity to the foramen magnum. That's very important to remember. Sternocleidomastoid trapezius, test head rotation, shoulder shrug against resistance, able to shrug ipsilateral shoulder. So ipsilateral, that you must static lymphadenum neck dissection, blunt or penetrating neck trauma. Last questions. Okay, so tongue deviation to the left side. So tongue deviation will be on the same side. Okay, it will lick their own wound. So that's how you can remember on same side, okay? Uvula on opposite, tongue on same side. That will be left cranial nerve 12. Damage to hypoglossal nerve result in atrophy of which muscle? Gynoglossus. Okay, so it supplies the gynoglossus. That's you must remember. Exits hypoglossal nerves. Any injury to the hypoglossal nerve function, motor, all breathing and swinging the muscle of the tongue. Assessment, power and symmetry of tongue protrusion to look for deviation. Clinical effects, semiparalysis of tongue with wasting and fasciculation, tongue deviation toward the weak side, penetrating trauma, tumor, meningitis extension. Okay, that's the end of session. Any question? Could you please keep on revising the recall file, which I have provided, and also the PrepXpert file, okay? Okay, ji, Allah Hafiz. Any question you can ask in the box. Uh, Next session will be most likely on Saturday if Dr. Ibrahim will available. I will ask him and then give you time because I am busy till Tuesday. So I will not be able to conduct the session. I have my own commitment. Okay. So head and neck that will be taught by Ibrahim. If I will conduct on Tuesday, I will teach CVS physiology, but let's see Dr. Ibrahim when teaches. He can teach on Sunday and Monday, but you must revise the head and neck anatomy report in next 1 and 2 days. Okay. Thank you very much.